I'd like to share with you the kinematic alignment with modified conventional instruments instead of the patient-specific guides which we use with the Otis knee. And so kinematic alignment can be performed a variety of ways. One is with patient-specific guides. This new way I'm going to share with you, which is modified conventional instruments. It could also be done with navigational instruments. So we're going to cover three topics on kinematic alignment. I'm going to try to answer the question, why kinematically align instead of mechanically align a total knee arthroplasty? What is kinematic alignment? Just a brief review. And then the technique of kinematic alignment with modified conventional instruments. We'll show you how to do this instead of the use of patient-specific guides or the Otis knee. So why kinematically align instead of mechanically align a total knee arthroplasty? Well, too many patients are unhappy with the mechanically aligned total knee arthroplasty. We occasionally have the patient with stiffness that we have to manipulate. We have the patient with mid-flexion or late flexion instability due to collateral ligament laxity. We have the patient with perfect radiographs but the so-called painful knee. And then we have wear and loosening. And it's curious that most of the time the wear and loosening is not in the center of the components as you see here, but it's usually on the back edge of the tibial component, and that's a sign of axial malalignment, not a coronal malalignment. The other problem with mechanically aligned total knee arthroplasty is the clinical outcome is inconsistent. And we learned this from Baker's study in JBJS, where they studied the role of pain and function in determining patient satisfaction after total knee arthroplasty from the National Joint Registry in England and Wales. They sent out 10,000 postal questionnaires, and at a year they got an 87% response. And what they found was a broad distribution of outcomes based off the Oxford score. And of concern was persistent pain in about 1 out of 5 patients, pain walking in 17%, and pain shopping in 16%. And only 9% reported no or hardly any problems with their knee. And so there is room for improvement, and we believe that kinematically aligning the knee provides you with this opportunity to improve the clinical outcome. So just as a brief review, what is kinematic alignment? In the simple terms, kinematic alignment strives to restore the 3 normal rotational axes in the knee. And it does so by shape matching the best size femoral component to the restored articular surface on the femur and tibia. And what this does, it co-aligns the 2 transverse axes in the femur with the femoral component, the transverse axis about which the tibia flexes and extends here in green, the transverse axis in the femur about which the patella flexes and extends here magenta, and then if the tibia is cut correctly, you end up having the IR-ER axis of the tibia properly aligned with these 2 transverse axes according to Coughlin, Eckhoff, and Howell's work. The principles of kinematic alignment are really straightforward. We just borrow 3 alignment steps from the uni knee, and that is we want to preserve all the collateral ligaments without lengthening them or releasing them. We want to remove the osteophytes in order to restore the length back to the collateral ligaments. And then we account for the wear when positioning the components. So we simply resurface the knee, we correct the deformity by filling in the worn area and retensioning the ligaments. So let's look at the technique of kinematic alignment with modified conventional instruments, which I began using in October of 2009 and have now performed about 500 of these as of January of 2011. So you can begin the operation by actually preoperative planning and calculating the amount of distal and posterior wear. So you then can measure the amount of correction that you have to do distal and posterior to restore the normal position of the femoral component on the femur. And this can be done with radiographs or MRI. And here's an example with MRI. You can see on the left is the lateral projection of the femur. Circles drawn on the articular cartilage, and there's no wear. And then if we move to the medial side in this varus knee, you can see that the cartilage loss is about 1.5 to 2 millimeters on the distal portion, but none posteriorly. And this turns out to be a relatively good rule of thumb, is that when you have wear, it's usually on one side. If it's varus knee, it's medial. If it's valgus knee, it's lateral. It's usually more distal than posterior. And so usually correct 2 millimeters from the worn surface, and posteriorly 0 to 1, depending on where the wear exists. So the key instrument interoperatively for verifying that you have your femoral component kinematically aligned is the caliper. And what you want to do is make sure that you measure the thickness of the two distal and the two posterior bone resections as you remove them, and adjust their thickness so that after you factor in the kerfer and the wear, that you actually make cuts that match the thickness of the condylar surface of the femoral condyles. And here's just a review. You can confirm the kinematic alignment by checking the thickness of each bone resection. So the sum of the thickness of the 4 bone resections, the 2 distal and 2 posterior off the femur, plus the thickness of the wear, and this is actually a valgus knee, and that happens to be the distal lateral, where you see the blue line, and it's about 2 millimeters of wear, and then the kerf of the blade, and they should all equal the thickness of the femoral component. And so here you see the distal medial. The distal lateral is a little thinner because of the wear, and the posterior medial and posterior lateral. So this would be a kinematically aligned femoral component because the 4 bone resections equal the thickness of the condyle of the femoral component. So the first step in the surgical technique is to prepare the distal femur. And what I like to do is take a 3/4 inch osteotome and align it just posterior to the apex of the notch and parallel to the posterior joint line, and then trace the upper and lower border of the osteotome, and this is where you want to have your distal femoral cutting guide rest. Now this happens to be a varus knee we're going to show you. Most of the cartilage is already worn away, but there's a very thin layer in a couple of spots. So you often have this sort of regional wear, and you want to make sure that you remove the cartilage so that the paddle of the distal femoral cutting guide will sit flush on bone and not on cartilage. And then you can almost automatically correct 2 millimeters, which will take the knee out of its varus position. So we now want to set the distal femoral cut, and this was done with a modified instrument. And here you can see that the medial paddle that's going to rest against the medial femoral condyle is advanced 2 millimeters to correct for the wear. And so that when we rest this distal femoral cutting block within the 2 lines that we marked above and below the 3/4 inch osteotome, we've now set proximal distal and varus valgus, and the extramedullary alignment rod is adjusted parallel to the femur to set flexion and extension. So this then sets 3 of the degrees of freedom of femoral component positioning, and then you simply pin the distal cutting block to the femur parallel to the posterior joint line, and then you can make your distal femoral cuts. So now you measure the distal femoral bone resections as you make them. And so here's the medial cut, and this measures in this particular case 6 millimeters. Remember, we had about 2 millimeters of wear, and that should mean that the lateral side should be 8. And indeed, when we measure this particular distal femoral resection on the lateral side, which does not have wear, it's 8 millimeters thick. So that means posteriorly we'd like to have about 8 millimeters of thickness on both of the posterior cuts as well. So now we have to set the other degrees of freedom of the femoral component, and this is done by posterior referencing. And so we have a special posterior referencing guide with interchangeable feet that can augment the offset to account for the wear up to 2 millimeters at 1 millimeter increments. In this case, there's very little posterior wear where these 2 feet are going to rest on the femur as it's way around the posterior backside of the femoral condyle, so we'll use the 0 offset. We're having a little trouble getting it in this small knee, so we're simply going to take a saw and remove a little bit of the tibia, which will allow the foot from the posterior referencing guide to rest directly against the femoral condyle. So when we're posterior referencing in neutral in this case, we can pin our 2 holes, and this will give us the location for the chamfer block, which will set the other degrees of freedom, which is anterior, posterior, IR, ER, and medial lateral. So next you want to measure your posterior femoral bone resections. And remember that our distal lateral was 8, our distal medial was 6. So we want our 2 posterior resections to be 8 as well, since we don't have any wear posterior medial. And so it's best when you put the chamfer block on to cut your 2 posterior resections first, because then you can make adjustments in IR, ER if you have to. And here's the strength of the caliper. In this particular situation, I made the cut and it was only about 4 millimeters thick. And so I thought, well, perhaps I put the chamfer block in incorrectly. But as I look, I can see that my saw blade was not down on the fletched surface of it. So when recut, we removed about another millimeter of bone. But since we made 2 cuts, each about 1.5 millimeters in kerf, that makes 2.5. Here's 3.5 and 4. We're about 7.5 millimeters thick posterior medially, which is close enough to 8 that we'll accept it. So the chamfer block, you need to stay on it with your saw blade, and the use of the calipers can help you decide if you've made your cut correctly. And so now we'll look at the posterior lateral bone resection and measure that. And again, we'd like this to be 8. And sure enough, as we measured, it is. So we've got balanced symmetric resections, and we've now kinematically aligned our femoral component after we make our anterior and chamfer cuts. Now, if you want, you can perform an interoperative exercise and compare the thickness of each of these femoral bone resections to the condyle of the femoral trial. And as mentioned, each bone resection should equal the thickness of the condyle after you correct for wear in the kerf. And remember that posterior medial, we had to make 2 cuts because we didn't have our saw blade directly on the chamfer block. It looks a little thinner than the distal cut, but remember, we had 1 extra saw blade removal, which is about 1 millimeter, 0.2 thickness of bone. And there's our distal lateral cut and our posterior lateral cut. And so now we've corrected for the varus deformity, and we've put the axes of the femoral component co-aligned with that of the femur before the onset of arthritis and wear. The next step is to set the tibial cut so that we properly restore the longitudinal axis in the tibia about which it internally and externally rotates on the femur. And so we need to also use the same principle as we did in the femur, and that is correct for the wear and remove an equal amount of medial and lateral tibial resection after we factor in the wear on the tibia. And so remember, the wear here on a varus knee is going to be medial, and so we want to make sure that the tibial guide is placed in some varus because the normal limb has about a 2 to 3 degree varus slope. And we'll go ahead and pin, and we're going to be conservative on our tibial resection in its proximal distal level, and we're also going to neutralize the posterior slope a little bit so that we can preserve the PCL insertion. And now we'll analyze the thickness and the slope of the tibial resection. And actually in this case, I think I removed about 1 millimeter or 2 more bone than I would have liked to, but you can see anterior, there's a little more bone than posterior. We haven't made a reverse slope because remember there's about 3 degrees of posterior slope in the liner. And we've taken just about the same amount of bone off if we factor in the wear on the medial side as we did on the lateral side. And this then restores the tibial joint line exactly the way that it was prior. Now, when we do the kinematic alignment, we like to preserve the PCL, and it's important that we also remove posterior osteophytes in order to restore flexion and extension. And here we have the knee in 90 degrees of flexion, lamina spreader in the lateral side. We've already removed the posterior osteophytes in the lateral side, and now we're removing the posterior horn of the medial meniscus. And in knees with a flexion contracture, it's very important you get the posterior osteophytes off and also strip the posterior capsule from the femur in order to restore extension. And there you can see the PCL, and it looks to be in good tension. We felt around the back there, and you can see that there is a small osteophyte in this case, not a large one, and we can simply remove it with a curved osteotome and strip the capsule. And before the trial reduction, it's also important to remove all the medial and lateral osteophytes. In the varus knee, you're going to have more medial osteophytes, and you need to do this to restore the length back to the medial collateral ligament. And this is important to do at this stage so that you can properly check the tension and the stability of the knee throughout the motion arc with the trial reduction implants in. Our final step before the trial reduction is to check the flexion and extension gaps. And it's helpful to use this spacer. We've adjusted it in this case to 11 millimeters. It fits nicely in flexion at 90 degrees with good varus valgus stability and symmetric space. It's actually a little loose in full extension, so we're going to crank it up to 13 millimeter gap, and that tells us the size of our liner. And now the knee's in full extension, has good stability at 0, and at 90 degrees also still stable. And that's one of the things, you tend to underestimate the thickness of the liner with the knee in flexion because of the weight of the femur. And now we'll perform the trial reduction. And what you want to do is assess the varus valgus and AP stability throughout the motion arc, and also the extent of the knee extension and flexion. And so at this stage, you may find that you're a little tight, usually on the medial or lateral side, and that's due to a error in the cut plane of the tibia. And so sometimes you have to recut the tibia another 2 degrees of varus or valgus to allow that knee to be perfectly balanced. And sometimes if the knee is tight in extension, you reduce the posterior slope, and if it's tight in flexion, you can increase the posterior slope 2 degrees. So here the knee perfectly extends. It actually hyperextends, equal to what the knee was probably when the patient was younger. Excellent stability throughout the motion arc. No anterior subluxation of the tibia on the femur. The posterior cruciate ligament is functioning, and we'll make sure that we mark the orientation of the tibial tray so that the tibia and foot are in a normal anatomic position. Now, if at this stage you find that that knee was snug on the medial side or the lateral side, or tight in extension or flexion, then you balance the knee by removing osteophytes. If you haven't done so, go back and check, and most importantly, adjust the tibial cut. You don't go back to the femur and do anything on the femoral side. So if you're tight in extension and flexion, simply remove more tibia. If you're tight in extension, remove your posterior osteophytes, strip the posterior capsule, and decrease the posterior tibial slope 2 or 3 degrees, and that often will get your knee in extension. If you're tight in flexion, then if you can, increase the posterior slope 2 degrees. If you're tight medial, make sure you got rid of those medial osteophytes, and you might often recut that tibia in about 2 degrees more varus. Don't go more than that. That's about all you need. And if you need to, you can still lateralize the tibial component and remove the overhanging bone medially, and that will give you some slack of the medial collateral ligament. And on the lateral side, if it's tight, you just do the reverse that you did on the medial side, remove the osteophytes, recut the tibia in more valgus, and medialize the tibial component on the tibia. So now we'll do the final reduction, and we've now cemented the components. You can see the patella in place, and remember, we have all the kinematic axes aligned, so that patella ought to track just perfectly, and you can see it sits right in where it should be. Excellent stability with hardly any play through the motion arc. Symmetric internal-external rotation at 9 degrees, showing that the tibial cut was correct, and we're not binding on one side more than the other. Now let's look at our patient 24 hours post-operatively. She had the surgery done under general anesthetic. There were no blocks used. She simply had Toradol and Marcaine intra-articularly, Toradol IV Q8, and some oral narcotics. And here she is, just about 24 hours, little bruising developing on the back of the leg. But she can get up out of a chair without any assistive device. She has no IVs in, just a hep block for the administration of the IV Toradol. She doesn't need a Foley because her operation was short. There's no tubes coming out of her back from an epidural, and she can get up and walk on this knee and has very nice flexion, probably close to 90 degrees. Little extension lag, as you'll see here in a moment, just due to the quads being a little sore. But this is a good knee, and will have a very rapid recovery and get this patient back to an independent lifestyle very quickly. So to summarize, Kinematically aligned total knee arthroplasty has been a lot of fun and has been a new horizon for us in terms of how to perform total knee arthroplasty. There have been promising results in multiple studies, and in 23,000 kinematically aligned total knee arthroplasties performed by about 300 surgeons in 4 continents with patient-specific guides. Kinematic alignment with modified conventional instruments has been an effective surgical technique in my hands in the last 500 total knees that I've done beginning in October of 2009 until January of 2011. And we use the same alignment principles whether the knee is in varus or valgus or has patellofemoral arthritis, and that is simply adjust for the wear, resurface the femoral condyle with the femoral component in the position, and restore the joint line as it was before the patient developed arthritis. And the key to kinematically aligning the total knee arthroplasty is use the caliper intraoperatively. It provides a very effective way for judging the proper placement of your component before you cement the knee. And measure your bone resections. They should all be equal in thickness with the exception of the worn side where it'll be usually about 2 millimeters thinner, and posteriorly there isn't very much wear, so there may usually only be a difference of about 1 millimeter between the two posterior bone resections. Mechanical alignment, as we've seen in our practices, too often resulted in an unhappy patient that complains of instability, stiffness, and pain. And so the kinematic alignment, while not a perfect technique, has reduced these complications in our hands compared to what we found with mechanical alignment. And if kinematic aligning the total knee arthroplasty interests you, then you might do an informal survey. Ask your patients what their physical therapists that come to their home, what their friends and relatives say about their rate of recovery after a kinematically aligned total knee arthroplasty than the experience that they may have had with a person with mechanically aligned total knee arthroplasty. And if you have a patient that has a kinematic and mechanically aligned total knee, one in each limb, ask them which knee they prefer, and I think that you'll find that the majority of them, if not majority of them, will consider kinematically aligned knee the better knee. And if you have any other interests in this topic, feel free to go to my website. We have surgical techniques and journal articles and these presentations on the website for your review.